Hello everyone, I'm back again, but this time I've got some flashcards for revision of MRCOG exams. Now these are mainly from the guidelines and there's only volume 1 of these flashcards and I'm hoping to make many more of these for quick revision just before your exams. Now if you haven't already, then please hit the subscribe button and like this video and comment if there's anything specific that you would like me to make a video for. So amniocentesis should not be performed prior to 15 weeks of gestation. Chorionic villus sampling, shortened to CVS, should not be performed prior to 10 weeks of gestation. CVS, chorionic villus sampling, should be performed from 11 weeks of gestation. In multiple pregnancies, there's additional risk of miscarriage is about 1%. The additional risk of miscarriage following an amniocentesis and CVS is below 0.5%. Gestational trophoblastic disease (GTD), the incidence is 1 in 714 live births. The cure rate is about 98 to 100%, and a chemotherapy rate of 0.5 to 1% is seen for gestational trophoblastic neoplasia after partial molar pregnancy and 13 to 16% after complete molar pregnancy. Vaginal bleeding is the most common presentation of molar pregnancy and is seen in about 60% of cases. For any miscarriage, a urine pregnancy test is recommended to be done 3 weeks after the miscarriage. For complete molar pregnancy, if HCG has reverted to normal within 56 days of the pregnancy, then follow-up will be for 6 months from the date of the uterine removal. If HCG has not reverted to normal within 56 days of the pregnancy, then follow-up will be for 6 months from normalization of the HCG level. Follow-up for partial molar pregnancy is concluded once the HCG has returned to normal on 2 samples at least 4 weeks apart. FIGO scoring system for your molar gestational trophoblastic neoplasia. It's important to note what sort of criteria is used, so things like age, antecedent pregnancy, interval months from end of index pregnancy to treatment, pre-treatment serum HCG, largest tumor size, including uterus in centimeters, size of metastases, number of metastases, previous failed chemotherapy, and then it goes on to score it from 0 to 1 to 2 to 4. The cure rate of women with a score of 6 or less is almost 100%, while the rate for women with a score of 7 or greater is 94%. Gestational trophoblastic disease treatment centres in the UK are Charing Cross Hospital in London, Weston Park Hospital in Sheffield, and Ninewells Hospital in Dundee. Corticosteroids are offered between 24 and 34 plus 6 weeks gestation when preterm birth is imminent. For planned cesarean section birth, between 37 weeks and 38 and 6 weeks, an informed discussion should take place between the patient and the healthcare provider. Benefits of corticosteroids should be discussed, and also the potential harms. Benefits like it reduces admission to the neonate of the neonate to the unit for respiratory morbidity. Harms are things like neonatal hypoglycemia and potential developmental delay. Antenatal corticosteroids reduces neonatal death when the first dose is given within the 48 hours prior to birth. Antenatal corticosteroid administration affects fetal growth. Babies who receive antenatal steroids have a lower birth weight. Encourage women we're not using epidural to adopt an upright or lateral position in the second stage of labor, as this reduces the rate of assisted vaginal birth. Assisted vaginal birth meaning, um, an instrumental birth, which means that where a forceps or a 1-2s or a vacuum is needed to deliver baby. Encourage women who are using epidural to adopt a lying down lateral position rather than upright position in the second stage of labor, as this increases the rate of spontaneous vaginal birth. It's very important to know that these birth positions that are recommended in the guideline, because there are questions in your MRCOG exams from exactly being, just about these positions. So it's important to just get the difference correct. Um, the use of vacuum is not contraindicated following a FBS procedure or application of FSE, which is a fetal scalp electrode. Operators should be aware that there is a higher risk of subgleal hemorrhage and scalp trauma with vacuum extraction compared with forceps at preterm gestational age. Vacuum births should be avoided below 32 weeks and should be used with caution between 32 and 36 weeks. Discontinue vacuum assisted birth if there has been two pop-offs of the instrument. A less experienced operator should seek help after the first pop-off. Discontinue rotational forceps birth if rotation is not easily achieved with gentle pressure. In forceps, discontinue following 3 pulls by an experienced operator. Medial lateral episiotomy, the cut should be at 60-degree angle, initiated when the head is distending the perineum. Single prophylactic dose of intravenous amoxicillin and clavulanic acid, which is comoxiclav in short, antibiotic, is recommended following assisted vaginal birth. From around 20 weeks of gestation, the gravid uterus reduces venous return in the supine position. The cardiac output is reduced by up to 30 to 40%. Weight gain in pregnancy, large breasts inhibit the working space, and laryngeal edema. All this makes intubation more difficult in a pregnant patient. A left lateral tilt of the woman from head to toe at an angle of 15 to 30 degrees on a firm surface will hopefully relieve aortocaval compression in the majority of pregnant women. Ventilation rate should be at 10 breaths per minute with continuous chest compressions at a rate of 100 to 120 per minute. More than 20 weeks gestation, if there's no response to correctly performed CPR within 4 minutes of maternal collapse, or if resuscitation is continued beyond this, then perimortem caesarean section should be achieved within 5 minutes of the collapse. Antidote to magnesium toxicity is 10 mL of 10% calcium gluconate or 10 mL of 10% calcium chloride given by slow IV injection. Local anesthetic toxicity, if that's suspected, then stop injecting immediately. Intralipid 20% should be available, and in some cases will need to be given to the patient. For anaphylaxis, 1 in 1,000 adrenaline, that's 500 micrograms, 0.5 mils, IM should be given. It's very important to note that this is intramuscular only. For a patient with PROM, which is preterm, pre-rupture of membranes, erythromycin for 10 days is recommended, or until the woman labors, whichever comes sooner. The median latency after PROM is 7 days and tends to shorten as the gestational age at PROM advances. Pre-PROM complicates 3% of pregnancies and is associated with 30 to 40% of preterm births. Well, that's it for now, and I hope you found this video useful, and if you have, then please give this video a thumbs up and subscribe to my channel, and also hit in the comment below is there anything specific that you would like to watch on this channel to help you with revision of your MRCOG exams. Good luck revising.